Kristen Atchison here, and today we're going to do Chapter 16 about therapies. So the goals of therapy are to increase overall psychological functioning, to reduce those inappropriate destructive behaviors that we see in these psychological disorders, and to better understand ourselves and others. Some people have one of these goals, some people have all three of these goals, some people have a combination of several of these goals. But these are the kind of overarching goals that therapists have for their patients. Therapy is kind of broken down into several different kinds of therapy, overarching types of therapy, and providers. So we see that about 41.6% of treatment of these psychological disorders is coming from physicians. So this is going to primarily be a medical therapy, so drug therapies, things like that. We see that mental health specialists are making up about 38.6% of the therapy that's being provided for patients, and that we see that about 19.8% is being provided by other professionals. This can include things like clergy, most religious training programs involve some sort of counseling training, because that is usually a large part of that can be a large part of their job. So we see that about 20% of this kind of counseling and therapy is being provided by other professionals as well. So the different kinds of therapists we're going to talk about, we have a psychologist. And a psychologist can be either a clinical or a counseling psychologist, and they hold a doctorate in psychology. They're trained in the testing, evaluation, diagnosis. They're trained in therapy, research, and prevention of mental health and emotional disorders. So again, when I say that I don't have the qualifications to diagnose anyone, that's because I am not a clinical or counseling psychologist. I have a doctorate in psychology, but my training was not geared towards psychological testing, evaluation, diagnosis, and psychotherapy. So I don't have, again, these individuals have gone through a doctoral program that is aimed at those specific things, and that's why they're able to provide diagnoses and help for individuals in need. A psychiatrist actually holds a medical degree, so they are an MD, and they have an expertise in diagnosis, treatment, and prevention, again, of these mental and emotional disorders. They also have the authority to prescribe medications or other medical procedures. And sometimes you'll see that psychiatrists really want to go that medical route. And sometimes you see psychiatrists that want to do both kind of the medical route and other kinds of therapy as well. So it really depends on the individual psychiatrist's kind of perspective and the kind of environment that psychiatrist is in as to what kind of treatment that they're really providing. We see a social worker is another kind of therapist. They are helping with the situations. This is usually more situational based. So when we watched that video in class from John Oliver, we saw that example of that assisted community training or assertive community treatment. That ACT team. And again, that woman was a social worker. She was talking about the situation. She said, we'll do everything in our power to keep that individual in and functioning in the community. So again, this is about situations, poverty, conflict management, abuse, homelessness. Usually they have a master's degree to be able to provide therapy as well. So you'll see an MSLW, a licensed master of social work. And so we'll see that, again, that is a type of counselor or type of therapist. Again, they can do some of the diagnostic and treatment services as clinical psychologists, but they're not going to have that psychological testing because, again, they've gone at it through the social work aspect. And finally, we have a counselor. The counselor has a master's degree in counseling and has expertise in assessment, counseling, and therapy techniques. And they're going to really kind of pay more attention than some of the other therapists possibly to other kinds of well-being, including spiritual, educational, professional, and they also going to focus more on on prevention as a part of treatment. Okay, so preventing mental illness, and we'll finish up our discussion of therapy with prevention at the end. So there's two main kinds of therapy that we're going to talk about today, two kind of overarching kind of major types, one of which is psychotherapy. And when we think of therapy, this is typically what we're thinking about. This is the treatment of emotional, behavioral, and our personal problems through psychological techniques. So when you hear somebody's in therapy, they're, they have a therapist, this is what you're thinking about. Typically. Again, this is designed to encourage understanding of problems, modify troubling feelings, behaviors, and relationships. The other one that we talk about is also a kind of therapy, biomedical therapy. And this is the use of medications or other medical treatments to relieve the symptoms associated with these psychological disorders. So again, both of them are different kinds of therapy. When we think of therapy, we tend to think of more psychotherapy, but that's really a sub-branch of therapy. Biomedical therapy is also where we're giving medication, and those sorts of things is also a type of therapy as well. Okay, first we're going to talk about the different kinds of psychotherapy, and then we're going to come back and talk about biomedical therapies. So these are the kinds of psychological therapies we're going to talk about. There are other therapies out there. These are kind of the most predominant or the most well-known. So some of these we don't really use as much anymore. They have more of a historical value, or some of them are used quite a lot right now. So psychoanalysis is coming out of Freud, so it's coming out of his theory of personality. Okay, so the id and the unconscious and all of that stuff is where his this treatment is coming out of. And remember, he developed his theory based off of observations of people in these kind of therapy situations. So the overall goal is to bring the unconscious conflicts and repressed memories and feelings into conscious awareness, okay? So remember, he thought a lot of stuff was going on in the unconscious that was really motivating our behaviors, and he, and all his defense mechanisms and all of those that we learned about in the personality chapter, again, is what he thinks. This is a component of what he thinks is going on. And so his therapy is set up to, again, address these unconscious conflicts, these kinds of defense mechanisms, and bring them into the conscious awareness so that they can be handled. So the way it works is under the direction of an analyst or a therapist. The patient gains insight into unconscious conflicts and can let go of anxiety and other symptoms. The idea that we get of about, somebody laying on a couch and talking about these past memories and these sorts of things, that's coming out of Freud's psychoanalysis. So that's where that's coming from. And so again, you can look up Freud's famous couch and there's a picture of it. So again, that idea is really, it's kind of historically and culturally kind of part of what we think about as therapy now. So again, this one's not used as much. This one's really not used very much at all anymore. It has a contemporary version of it that is still sometimes used. But again, this model is what we think about when we think about psychological therapy. So it has a really important historical context. So contemporary psychodynamic therapies, and again, this is going to be kind of the more updated version of Freud's therapy, still include that interpretation of hidden feelings and memories, but it's more of a collaborative process and a dialogue as opposed to that one person talking and the therapist listening. There's less free association, and the therapist is not really an interpreter, and the client and the therapist face each other. So again, that idea of on the couch looking away and all of that is again from Freud's older, that kind of past. Even the people that really still adhere to Freud's theory and Freud's techniques still aren't doing that, okay? So again, that is kind of a historical model that we see dramatized in a lot of different things. we see that really only psychodynamic therapies are really happening in short-term based, and they're usually focused on very, very specific problems, usually relationships. We also see that most insurance companies don't really support these well because they do have limited effectiveness, especially for things like psychological disorders. So they really aren't being supported financially that way. Again, these are very short-term based and are very specific problem based when they're still being used. So remember, our backlash to Freud was humanistic in personality. And again, so humanistic therapies are going to come out of that same humanistic theory on personality as well. So again, these are focusing on the present rather than the past. Remember, we had that backswing between Freud being very, very negative and very, very past-based, and then humanistics being very, very positive. They're very, very present-based. So again, we have that backswing between those, and that's important to remember in that historical swing. And again, it's in that polar opposite. They're emphasizing conscious rather than unconscious thoughts. So we're talking about what you actually know about versus what you don't really have in your awareness. It really stresses taking responsibility for one's feelings or actions. So there's nothing in you that's causing you to do this. You have to take responsibility for your actions, for your feelings. No one can make you feel a certain way. You choose to feel that way. Again, there's that responsibility in there. And it really has a, because it's that humanistic theory, and because of it's coming out of that humanistic idea of personality, it really assumes that inherent potential for self-fulfillment and growth. Remember, humanistic theory was really sunshine and rainbows, right? Everybody was going for this self-actualized state. Everybody's, constantly trying to better themselves. So that's really a central kind of assumption in this theory. Remember, some of the humanistic theories came from Carl Rogers, and so he had a client-centered therapy as well. Therapists are expected to show 3 traits to nurture client growth. They need to be genuine. Remember, he called that acceptance. There needed to have that that unconditional positive regard and empathy. So those are the 3 things that, remember, we talked about in humanistic theory in the personality chapter. They're what he says a therapist really needed to have and to show these traits so that the client could grow. This therapy really focused on active listening. So restating and clarifying what you feel the client is saying. So this really served 2 purposes, according to Rogers. One, that it demonstrated that empathy that he was looking for, that you were tuning in to what that person was saying. You were really listening to what they were saying. Again, remember, this is kind of in some ways a backlash to Freud. So that idea of the therapist not listening and drawing pictures while you're talking, and again, this is things that are dramatized in the media, they kind of felt that. And so again, this is a backlash to this. So instead of the therapist being very silent and very not attached, very detached from the individual's talking and thoughts like we saw with Freud, this is kind of the polar opposite again. And we see that Rogers' client-centered therapy was very, very attached to the extent that they would repeat what that person was saying in a different way. So reframe it. They also said that this helps build the client's awareness and acceptance of their own strengths and feelings. So that this was going to help the client better understand what they were thinking and accept those feelings as well. So the client would say something and the therapist is going to come back. So what you're saying is, and they're going to restate that for them. So that again, it demonstrates that the therapist is involved and is tuned in and is empathetic, but it also allows the client to hear what they're saying, to understand it from a different perspective. And it allows for that piece that's acceptance, which again was a big component of Rogers' theory. So the next theory we're talking about is behavioral therapies. And again, this is that same historical progression that we've had all along. So we had Freud, really, really negative. We had behavioral, we had humanistic, very, very positive, both of which are not very scientifically based, okay? Then we hit the behaviorists, and the behaviorists are all about things that you can measure. You can't really measure the things as well in the humanistic perspective or the psychodynamic perspective. Those don't have a lot of concrete measurements. They don't have a lot of scientific backing because we can't really measure the things. We can't really operationally define the things that we're talking about. Behaviorism comes around, and again, this is the behaviors we can measure. A lot of the conditioning was happening, classical conditioning, operant conditioning is happening in this behaviorism time period, this behaviorism theory. So just as you would expect, a therapy comes out of this as well. And so behavioral therapies don't seek to explain these disorders. They're not looking at unconscious, they're not looking at self-awareness or insight. They're assuming that this is learned behavior. Behaviorism, we're talking about conditioning, we're talking about learning. That's that learning chapter we have is a kind of on behaviorism. And so again, they're assuming that this is learned behavior through either operant or classical conditioning. And so the way that they relieve these symptoms is by changing the rewards and punishments that are influencing the problematic behaviors. So that would be done with operant conditioning. So again, the negative rewards, negative reinforcement, negative punishment, positive reinforcement, all those things that we learned about in the learning chapter with operant conditioning are the tools that these behavioral therapists are using to change symptomology, to change behavior. And they also do it by building new associations to disrupt unwanted panic or other automatic responses. And this is done through classical conditioning. So they're building, again, this associative learning, making new associations between these things. So here are some examples of behavioral therapies, one of which is exposure therapy. And exposure therapy is a form of counter conditioning. So conditioning is when we're teaching something, right? That's learning. Counter conditioning is when we're going to try to unlearn that thing. Okay, and exposure therapy is one way that they're trying to unlearn these disruptive behaviors. Okay, this is especially used to treat phobias. The emotion arousing stimulus is confronted directly and repeatedly, ultimately leading to the decrease or elimination of that response. So if somebody has a phobia of snakes, first they're going to do things like talk about snakes. And usually if you have a phobia of snakes, even talking about snakes is going to create some sort of panic. So they're going to expose them to that really low level exposure talking about snakes. Then they'll be showing, once we get comfortable there, then we'll show pictures of snakes. And then there'll be a snake in another room, and then there'll be a snake in the room, and it eventually ends up, and this is a long-term process, this is not over a day, this is over many, many sessions, depending on the severity of the phobia and these sorts of things, the length can vary, but it really ends with maybe holding the snake and being really okay with that. And again, this is that counter conditioning, creating those new associations. One way that they do this is that systematic desensitization. Again, this is that technique where they're combining these fear-inducing stimuli with relaxation, muscle relaxation, different kinds of coping mechanisms to eliminate that negative arousal. So there's someone scared of an elevator and they have learned all these different techniques on how to reduce their stress and all these things, and they finally go up 2 floors on an elevator by themselves, and they have all these tools with them to kind of help them deal with this emotion arousing, all these kind of muscle relaxation, breathing, these sorts of things. Another example of counter conditioning is aversion therapy. And again, this is another counter conditioning. We're trying to unlearn something. And this is used to treat unwanted habits or harmful behaviors. So an unwanted state is associated with that unwanted behavior. We can see this done with Some alcoholics, we've seen people use aversion therapy for alcoholics, and that's what this image is here. They're using that same classical conditioning model. Where there's an unconditioned stimulus and an unconditioned response. The conditioned stimulus is added to that unconditioned stimulus, and then we get that unconditioned response. And eventually we have that linkage between that conditioned stimulus and that conditioned response. So here the example would be, there's a drug that induces nausea and vomiting. Okay. And what they're going to do is they're going to pair that drug, that thing that makes you feel sick, with that unwanted behavior. Okay. So that unwanted state of nausea is being linked with that unwanted behavior of drinking in this case. Those two things are paired and we result in nausea. And again, we have this pairing over and over and over again until that idea of alcohol itself can produce the nausea. So again, we're pairing these things so that that unwanted behavior, alcohol, is no longer engaged in. So again, this is another form of counter-conditioning where we're trying to unlearn. So aversion therapy and exposure therapy, we're trying to counter-condition somebody, we're unlearning. And these are coming out of that behavioral model that we talked about in that learning chapter when we talked about conditioning and learning and imitation and those sorts of things. After behaviorism, we really got into a more cognitive kind of perspective. So again, this is following that same historical perspective that we've talked about throughout the class. And again, with the onset of computers, they started thinking about more of these thoughts again, not just behaviors, but thoughts as well. And so we're now into these cognitive theories. And these cognitive therapies. So it's again based on the assumption that psychological problems, especially in the from this cognitive perspective, depression and anxiety, are results of illogical patterns of thinking. They call these irrational beliefs or cognitive distortions. And again, this is then what they're going to try and do is change this pattern of thinking into a more positive, less unhealthy pattern. So they're going to really focus on recognizing these unhealthy thought patterns and altering these unhealthy thought patterns, with the idea that then the symptoms of anxiety and depression will be alleviated because these patterns of thinking have been changed. One person that really pioneered this was Beck. He said that depressed people really distort experiences and maintain negative views of themselves. And again, they're misattributing these negative experiences to their own deficiencies. So again, in our textbook, in that psychological disorders chapter, we didn't have time to cover it in class, but the textbook talks about again, how these different patterns of thought, that kind of pessimistic thinking, can really exacerbate or create depressed moods. And so Beck is operating off of that idea, that this negative pattern of thought is really this focusing on these negative views, focusing on their own deficiencies is really what's causing or exacerbating the symptoms. This therapy really challenges these ideas, this negative thinking, or what they're calling these cognitive distortions. They also focus on things like all or nothing thinking. So it's either all one thing or the other, or nothing. There's nothing in the middle. And again, we know that pretty much everything is not one way or the other. There's usually middle ground. So again, that's an example of a cognitive distortion. Making everything into a catastrophe. Everything is the end of the world is another cognitive disorder. Discounting the positive. We see that with that depressed mindset where positive things are discounted and the negative things are, again, kind of focused on. And overgeneralization. So if somebody says something rude to you, making that about that person doesn't like you instead of that person was in a bad mood. I mean, again, that's focusing on those negative experiences, those negative, trying to make it into a deficiency. And really Beck's cognitive therapy was trying to counteract that, saying, no, we're going to change this pattern of thought, and this will help alleviate symptoms. So the treatment really focuses on recognizing these automatic thoughts, these automatic beliefs, and these automatic patterns, and changing them. Clients are directed to test whether these beliefs are true And then ultimately they'll come to the realization that they're not true, that these are unrealistic. So these thoughts are being tested kind of by the individual to show that they're not really happening. Again, we've got this kind of this progression where we went from Freud through humanistic into behavioral and into cognitive. And both behavioral and cognitive had a lot of really good, they have a lot of really good data behind them that really supports both of them well. And so what we see right now as a big therapy technique is kind of the blend of cognitive and behavioral training. Just like psychology is no longer just behaviorism or just cognition. We've got both of them, that it's both mind and it's both thoughts and behavior are a crucial part of psychology, the study of both mind, thoughts, and behavior. That's where we are with therapy as well. So one of the major techniques that we're seeing now is cognitive behavioral therapy. It's often called CBT. And it's the idea of this interaction, and again, this is a common thing too, where we are in psychology is these interactions between these different things. It's not one or the other. It's, again, this middle ground. It's this interaction between things. So the aims are not necessarily to alter the way people think, their cognition, but to also alter, not only alter just their thoughts, but their thoughts and their behaviors, okay? So again, it's this interaction. So the way we think affects how we feel. What we do affects how we think and feel. And what we feel affects what we think and do. So again, we have this triangle, we have this interaction between all three of these components. And cognitive behavioral therapy is trying to look at the confluence of them together and treat that so that we can alleviate symptoms. Again, this seeks to make people aware of this irrational thinking. So that piece of cognitive therapy is still there. This irrational negative thinking is addressed, but it's also addressing the behaviors that are related to that negative thinking. And we're replacing that with a new way of thinking and new behaviors in everyday settings. So these negative behaviors, these negative thoughts are being replaced and being replaced with these positive. This is often described as problem-focused, action-oriented. It's very structured, it's very transparent, but it has a lot of flexibility for the individual because these different thoughts are going to be different for different people, these negative thoughts, these negative behaviors, and different disorders, they're going to be different, and an anxiety disorder versus a mood disorder, they're going to be different. And so it allows flexibility to kind of address those differences and those nuances within the individual. So an example would be a client with obsessive compulsive disorder who fears the contamination in public restrooms. They may be instructed to visit 3 restrooms in a week. Again, this is the idea that they are challenging that irrational thought, okay? Challenging that irrational thought of contamination by going into a public restroom. And they're pairing that with the behavior change. They're not just doing the thought pattern. We're not going to just change the thought. We're going to add that behavior in there. That behavior is an important component. So going to those public restrooms will help change those thought patterns. That behavior helps change those thought patterns. So again, this interaction between thought and behavior and emotion. Another type of therapy technique we have is group therapy. This we see this a lot in a lot of different settings. It can be inpatient, it can be outpatient. And the idea is that people with similar problems gain feedback and reassurance from knowing that other people have these similar situations. So all the anonymous groups, so Alcoholics Anonymous, Gamblers Anonymous, Narcotics Anonymous, all of the various anonymous groups are going off of this group therapy technique. This idea that benefit from knowing other people with similar problems, getting feedback and reassurance is really, really helpful. Under group therapy, family therapy also is considered part of this. And it's the idea, again, that these things are not separate. It's not one person is having a problem in the family. If one person is having a problem in the family, because the whole family is an interdependent system, that everybody has a role in that. Okay, and so it again is treating that whole unit as opposed to that one thing. So again, you can see where we are kind of now in that psychological perspective is we are about this interplay between things, interplay between cognition and behavior, interplay between other individuals and how that affects disorders. Couples and marriage therapy is a kind of group therapy. This fosters communication, intimacy, and problem-solving skills. And again, those various anonymous groups and other kinds of self-help and support groups, again, are doing the same thing. So self-help and support groups, there's not a designated therapist at an AA meeting or an NA meeting. They are, again, this common problems without that designated therapist, but it's still a form of group therapy. So we know that psychotherapy, both clients and clinicians report high rates of effective treatments, but because the people that are engaging this want it to work, there is bias that can be a problem, and they can be more subjective with that report. However, when we look at outcomes, we see consistently that psychotherapy is more effective than receiving no treatment. So psychotherapy does work as the take home. So we see that therapy is most effective when the problem is clear-cut and specific, when it's not pervasive and in all these different areas, when it's very kind of, it has clean edges. It's easier to attack. It's easier to control. So this is the percentage reporting improvement. And we see that both people with therapy and without therapy are reporting improvement. We just see that the rate of therapy reporting improvement, psychotherapy reporting improvement is higher initially. So they start to feel better sooner. And they continue to feel better over time as well. So again, we see a big gap in that outcome, that percentage of people reporting that this is beneficial. There's lots of factors that contribute to the effectiveness of psychotherapy. That relationship is really, really important. The relationship between the client and the therapist is a very important relationship because a lot goes into that. So that needs to be seen. That relationship needs to be seen as trusting, that caring, empathetic responsiveness that Rogers really focused on in his humanistic therapy is a really important part. We talk about his theory in some part because that is a really important thing that we learned from his humanistic, is that responsiveness, is that empathy, is really important in fostering that healthy therapeutic relationship. The client really needs to be motivated. The client really needs to be optimistic that this is going to be helpful. If you have decided that this is not going to work, it's not going to work. And so again, that motivation, that optimistic on the part of the individual is very important as well. Again, we need to have a proper setup for success, okay? So supportive family, stable living situation, these sorts of things. So again, when we watch that video from John Oliver, those are the things that they're talking about. Therapy isn't going to be as effective as when you walk out of that therapist's office if your life is in shambles. So again, that supportive environment is important as well. We also see that a culturally sensitive therapist is really, really important. So different cultures have different nuances, and we'll find that people will report more effectiveness when they have the same culture as their therapist, that there's a match there, or the therapist is really sensitive to their culture. So when you look at the different websites that I've posted to find therapists and things like that, you'll notice that there's things to select for things like language, for things like culture. And they do this because they understand that role of cultural sensitivity is very, very important. So if you're from a particular culture, you're going to feel that your therapy is more effective if that individual is from the same culture or is sensitive to your culture. So again, that match is really, really important. Okay, so we're going to move on to biomedical therapies now. primarily, we're going to talk about drug therapies. There are other biomedical therapies that include brain stimulation, which is covered primarily in your text. We're not going to really talk about that. And psychosurgery, which is also covered in your text. Things like electric shock would be a biomedical therapy that we're not going to discuss. There's other kinds of surgeries that can be done that, again, we're not going to discuss. Those are covered in your text. And so I'll let you go there. We're going to really focus on what we hear about most, these drug therapies. So biomedical therapies use medications or other medical treatments. And again, those can include surgery. Those can include brain stimulation. Or other body interventions to relieve the symptoms associated with those psychological disorders. So these biomedical therapies are really focusing on the idea that, yes, there's a biological component to these disorders. And so they're dealing with that biological component. Where the psychological therapies, the psychotherapies, we're saying, okay, there's a psychological component to this. Let's focus on that. The most widely used biomedical therapy is drugs, is the psychotropic drugs. So these prescription drugs that alter the mental functioning and alleviate these psychological systems. So Prozac, Wellbutrin, all of these kinds of things are these psychotropic drugs that are altering mental functioning. Zoloft, Paxil are altering these things and improving these psychological symptoms. So we're going to focus on these drug therapies because, again, they are the most widely used biomedical therapy. So we're going to focus there today.
Psychoactive drugs change the way the brain functions by altering neurotransmitter release, binding, reuptake, or breakdown. One class of psychoactive drugs binds directly to receptors and activates them, mimicking the normal effect of a neurotransmitter. Nicotine is an example of a drug that acts in this manner. A second class of psychoactive drugs binds to receptors but has no effect. By occupying receptor sites, but not stimulating activity, these drugs act to block the normal effect of neurotransmitters. Haldol, a drug commonly used to treat schizophrenia, acts in this manner. A third class of psychoactive drugs, commonly known as reuptake inhibitors, blocks the activity of proteins on the presynaptic membrane that normally recover neurotransmitter molecules from the synaptic gap. These drugs keep neurotransmitter molecules in the synaptic gap for an extended period of time, significantly increasing their effect. Prozac, a frequently prescribed antidepressant drug, is a selective serotonin reuptake inhibitor, SSRI. A fourth class of psychoactive drugs blocks the natural process of enzymes that break down neurotransmitter molecules released into the synaptic gap. When the activity of these enzymes is inhibited, neurotransmitter molecules remain active in the synaptic gap for a longer period of time. Nardil, another frequently prescribed antidepressant drug, is a monoamine oxidase inhibitor, MAOI.
So again, you may have heard some of these drugs. You may have heard some of these SSRIs, MAOIs, all these different things. And again, these are these different kinds of drug therapies that are used to treat psychological disorders. Again, you can see how they're working. So we know that we better understand how neurotransmitters are involved in these systems, these disorders. So we're addressing those neurotransmitters and addressing how those neurotransmitters are functioning or not properly functioning, so that we have better outcomes from this biological level. The second generation of antipsychotics. So the first ones that really came out were things like Haldol that they mentioned in the video. And Haldol was very, very effective at treating these negative, these positive symptoms of schizophrenia and positive psychotic symptoms. But it has a lot of really negative side effects. So people who are on it for a very, very long time develop usually what is called Parkinsonian symptoms, where they have the tremors that really resemble someone who has Parkinson's disease. And again, we know that this is a long-term side effect of continued Haldol and other first-generation antipsychotics. So these second-generation antipsychotics were developed to really kind of counteract that. So these typical antipsychotics, the things like the Haldol, is again where we saw a lot of those Parkinsonian symptoms. So because of this, these atypicals were developed in the 1990s. They block both dopamine and serotonin. The ones that we see most are like risperidol and Abilify. And we see down here below that both the trade name and the generic name are listed. But the way that these work is, again, they're blocking these neurotransmitters. They still have a lot of side effects, but they are much less significant than those typical antipsychotics. So I spoke in class about my client when I was a mental health caseworker who had been diagnosed with schizophrenia in the 60s. He was prescribed Haldol. And because he had had this long-term, he was on Haldol and various typical antipsychotics for such a long period of time, he did develop some of those Parkinsonian symptoms. He had tremors. He had these really negative, significant side effects from these medications. So again, these things like these second generations, risperidol, Abilify, are again used to really treat the same things that the typicals were, but again, minimize some of those negative side effects. Some other medications, such as Zyprexa, have found to have risks related to obesity and then diabetes. And again, we can see that's especially problematic when we are dealing with people who have other health issues as well. So again, whoever's prescribing this medication is going to look at kind of the whole picture of the person. If their family has a high risk of diabetes, if they're already obese or have a risk of obesity, they're going to be less likely to be prescribed something like Zyprexa because of that. Anti-anxiety medicines, we see that the benzodiazepines are really one of the main group of anti-anxiety medications that are being prescribed. You've heard about a lot of these. Xanax, Valium, these are all those kinds. Lorazepam, Ativan are ones that you see prescribed. And again, you see that people will use these when they're not necessarily treating an anxiety disorder. What these medications do is they increase the levels of the neurotransmitter GABA. So it reduces brain activity. And again, this is really good for anxiety patients because, again, they have this overactive kind of neurotransmitter system that's going on. But that's why people are using them illegally as well, is because of this reduced brain activity. The side effects include really a negative interaction with alcohol. So this is especially problematic when people are using them illegally. With alcohol as well. Decreased coordination, motor function, and there's really a big risk of dependence here. So what we see is, in terms of drug addiction, one of the most common forms of drug addiction right now in the United States is prescribed medication, and they include things like, again, the Xanax, Ativan, Valium, these sorts of things. We also see that other medications have been helpful as well with anxiety, including Buspar, but they're not really sure as well how that medication is helping anxiety. They know that it is, but the neurotransmitter chemical level is not well understood right now. Mood stabilizing medications. Lithium is a naturally occurring substance, and it's really effective in the treatment of bipolar disorder, especially in that manic phase of the disorder. We see that mood stabilizers really work by regulating the excitatory neurotransmitters, and but the understanding of how lithium works is still is not well understood. So here's an image of an ad for lithium water. And again, they understood that this was affecting behavior and brains, but they didn't understand why. There's also an anticonvulsant Depakote, which we also see is very effective in treating bipolar disorder. Again, when I was a mental health caseworker, I had a lot of bipolar patients that were taking Depakote. Antidepressants, the most common one we know of, we all think about, is Prozac. And these are really affecting the serotonin at the synapses. So when you saw in that animation about how they were these SSRIs, they are affecting that serotonin. We see that this affects the neurotransmitters immediately, but it takes weeks for it to really build up this in the system and to really feel that therapeutic effects. So someone who starts taking Prozac, while it starts to work on their system immediately and their neurotransmitters immediately, it takes weeks to build up to really feel those therapeutic effects. So sometimes we have problems with people adhering to those medications because they're taking them and they don't seem to be doing any good. And again, there is a time period where you have to continue taking them to really before you can see that effectiveness. The side effects really depend on the type of antidepressant. They include things like dry mouth, constipation, decreased sexual responsiveness. I definitely had clients saying that they didn't want to take their medication because that negative side effect of sexual responsiveness. So again, there are negative side effects with these as well. These are also being increasingly prescribed for anxiety as well. We see that these biomedical therapies are really have a lot of positive use, are very effective for certain psychological disorders. But the actual effectiveness is kind of debated. So we see improvement in these individuals, but the understanding of and how that improvement is working is still in debate. The decision to use medications is, again, really complicated by side effects. Dry mouth, weight gain, decreased sexual desire, and again, these are really problematic, especially in things like these antidepressants that are taking 2 weeks to really take effect for effectiveness. So you can get these negative side effects from the medication before you get the effectiveness. So again, sometimes we see problems with adherence to these biomedical therapies because of these side effects. There was a lot, one of the things I did as a mental health caseworker was to really talk with my clients on how to talk about their side effects, how to talk about their symptoms to their psychiatrist so that they could work on balancing their symptoms and their side effects to a really place that they were comfortable with. So it was about talking about those different things, identifying them so that they could discuss them really well with their mental health care provider. So when we compare psychological and biomedical therapies, several large-scale studies have really done this, and they found that they're really comparable. So it's not that psychotherapy is better than biomedical therapy. It's not that biomedical therapy is better than psychotherapy. We see that they're about the same. What we are seeing is that when we combine these two things, we see much better kinds of outcomes. So again, when we're combining these psychotherapy techniques and we're combining these biomedical techniques, we're seeing much better outcomes. This again goes back to that biopsychosocial approach, right? The idea that is the confluence of biology, which is being treated by the biomedical therapy, psychology, and sociology, which are being usually addressed from that psychotherapy. So this interaction between them, when we're addressing all the three components, we see the best outcomes. Brain studies really indicate that psychotherapeutic and biomedical treatments have similar effects on the brain activity and similar effects on neuroprocessing. So because they're doing the same kinds of things, when we combine them, we get better outcomes. Finally, let's talk about preventing psychological disorders. So it is better to prevent than cure. An ounce of prevention is worth a pound of cure. There's tons of proverbs for these, and tons of folk wisdom, and that's because it really is easier to prevent than it is to cure. So the idea of preventative mental health is really focused on this healthy lifestyle. We talked about how diet and exercise and sleep really affect these things. We're increasingly understanding how being outdoors and how outdoor activities are really a crucial part of this as well. Social connections, we talked about that affiliation need, that need to be connected to other people. All of these things together really help promote mental health. So a healthy mind, and it really helps also alleviate the symptoms of these psychological disorders. So again, diet, exercise, adequate sleep, outdoor activity, all of these things are really important for effective, for true mental health. So again, we see that all of these things are working together. So preventative mental health, we are looking at the idea that these can be prevented by societal programs that can alleviate the conditions that help foster poor mental health. Because we know that psychological and social areas can really exacerbate any kinds of genetic predispositions, programs that address these oppressive, esteem-destroying environments with these really positive. So programs that address poverty, programs that address education, programs that address these things are a piece of preventative mental health. Food stamp programs, because diet's an important part of that, address that. Community parks, because they're providing outdoor spaces, address that. So it again is about kind of replacing esteem-destroying negative environments with these uplifting, nurturing environments. And that kind of goes back to the developmental chapter and the nature-nurture chapter as well. This idea that we can really foster health from the beginning. Again, there's still genetic dispositions. There's still situations that can cause these, but preventative mental health is looking at, again, that whole person and how this confluence of situations really can be used to kind of minimize any negative mental health symptoms. So that wraps up chapter 16 for us. And this is our last video lecture for the Introduction to Psychology course. So thank you for listening. Thank you for being a part of this. And I'll see you in class.